Welcome back to another Explainer. Today we're throwing on our medical detective hats to investigate a truly fascinating anatomical anomaly, the dermoid cyst. We're going to explore how just a few misplaced cells, sometimes trapped before you're even born, or sometimes pushed under the skin by something as simple as a garden thorn, can create these complex, hidden structures deep within the body.
Okay, let's dive into this. Here's our four-part roadmap for today's clinical deep dive. We'll start by defining the dermoid cyst, then look at sequestration dermoids, move on to implantation dermoids, and wrap up with tubulo and teratomatous dermoids.
So, starting right off with Section 1, defining the dermoid cyst. At its absolute core, a dermoid cyst is this sac-like growth sitting deep beneath the skin. But here's the twist. It's actually lined by skin, specifically squamous epithelium. Because of that, you can basically think of it as an epidermal cyst. Now, what's inside? Well, clinical texts describe it as containing a pultaceous or, toothpaste-like material. This thick substance is literally just made up of desquamated or shed epithelial cells. It's basically the body's surface tissue doing exactly what it normally does, but it's trapped in a closed, deep pocket.
Right. Moving on to Section 2, sequestration dermoids.
Now, the sequestration dermoid is a congenital variety. That means you're born with the foundation for it already there. During embryonic development, as all the different segments of the body fold and fuse together, a few of those surface ectodermal cells can accidentally get trapped or sequestered deep down in the tissue layers. Fast forward, and over time these trapped cells proliferate, eventually liquefying to form a cyst. And get this, because bone often develops right near these fusion lines, the cyst can sometimes literally create a dent in the underlying bone. So, because these cysts start forming during embryonic development, their location on the body is a massive clinical clue. They pop up almost exclusively along very specific lines of embryonic fusion. You're going to commonly see them right in the midline of the neck or at the external angular point, which is just above the outer corner of the eye. They also love to show up post-auricular, meaning behind the ear, right on the skull itself, or at the root of the nose. If a patient comes in with a deep cyst in one of these exact spots, well, sequestration dermoid really needs to be at the very top of your differential diagnosis list.
When we actually look at the pathology of a sequestration dermoid, things get incredibly interesting. Since this cyst is lined by fully functioning stratified squamous epithelium, it doesn't just shed skin cells, it can actually grow hair. Yeah, it contains hair follicles, sebaceous glands, and sweat glands. So you know that thick toothpaste-like material we talked about earlier? Well, in this specific type of cyst, it's this rich, trapped mixture of sebum, sweat, shed cells, and often actual hairs. Diagnosing these cysts takes a really careful physical exam. First up, check the patient's history. Even though those cells were trapped before birth, the cyst itself might not actually be noticed until years later. It usually presents as a painless, super slow-growing swelling. And honestly, unless it gets infected, it rarely causes any real issues or disability. When you palpate it, it'll feel ovoid or spherical and smooth, but here's the kicker. It's tense. You can't compress or reduce it, and it absolutely isn't attached to the overlying skin.
And this brilliantly illustrates the absolute most critical physical difference between a dermoid cyst and your common sebaceous cyst. A sebaceous cyst, it's always going to have a punctum, that little dark pore or opening right on the skin surface. But a dermoid cyst, because it's trapped completely deep below the skin, no punctum, none at all. That single feature is a huge diagnostic key for you.
Now, before we get into treatments, I want to throw a high-stakes clinical question your way. If you have a patient sitting in front of you with a cranial sequestration dermoid, one right on their skull, why must you absolutely always perform an X-ray before taking them into the OR?
Well, here's the crucial point. You are checking for an intracranial connection. An X-ray might show a depression in the bone right under the cyst, or far more dangerously, an actual gap. There could be a fibrous band passing entirely through the skull, connecting that superficial cyst directly to the dura mater, the brain's protective membrane. You definitely don't want to find that out mid-surgery.
Because of that risk, treatment is highly delicate. While general risks include things like infection, suppuration, and ulceration, the definitive fix is complete excision under general anesthesia. The surgeon has to really carefully dissect the cyst away from the sensitive pericranium. And if that X-ray did show an intracranial extension, well, the operation just became a lot more complex. The surgical team will actually need to remove an osteoplastic flap just to safely excise the intracranial portion of that cyst.
All right, shifting gears to Section 3, implantation dermoids.
So, unlike the sequestration dermoid, the implantation dermoid is acquired. It happens after birth, and it arises from physical trauma. We're talking about a puncture injury, like a simple needle prick or stepping on a nasty thorn. This mechanical force literally drives a tiny piece of surface epithelium deep beneath the skin. The skin heals right over it, but that trapped piece of epithelium, it survives, it proliferates, and boom, it creates a cyst.
Because this whole process relies on puncture wounds, the locations map perfectly to where we use our hands and feet the most, aggressively. You'll primarily see them right on the palm of the hand, the sole of the foot, or anywhere on the fingers, especially the pulp or the tip. And demographically, they are highly common in professions that are prone to pricks, gardeners dealing with thorns, tailors working with needles, and historically, it was noted very frequently in women, likely tied to sewing and handcrafts.
There's also a major pathological difference between our two types. Remember how the congenital sequestration dermoid contains hair, sweat, and sebaceous glands? Well, in an acquired implantation dermoid, hair is usually completely absent. The contents are strictly that white, cheesy material formed by disquaminated epithelial cells and basic sebum. No hair follicles here.
So to summarize the clinical clues here, your most important diagnostic feature is a tense, firm swelling in the finger or the palm, usually accompanied by a history of a puncture wound. Though actually keep in mind, because these grow so slowly, patients almost always forget the initial injury. You might find a tiny scar on the overlying skin, and unlike our first type, this one can actually be slightly painful. Complications can include infection or bursting, and the treatment, once again, is just complete surgical excision.
Okay, moving into our final stretch, Section 4, tubulo and teratomatous dermoids. Let's systematically compare these final two variations and see how this really builds our understanding of just how versatile and kind of wild these cysts can be. First, a tubulodermoid. This develops from an unobliterated portion of an embryonic duct, like a thyroglossal cyst developing from the thyroglossal duct. It essentially just contains the secretions of those ductal cells. But then you have the teratomatous dermoid, which is wildly different. It develops from totipotent cells. Those are the cells capable of turning into almost any tissue type in the body. Because of this, a teratomatous dermoid doesn't just contain skin and hair. It can contain actual mesodermal elements. We're talking bone, cartilage, and even fully formed teeth. And you're usually going to find these in deeply internal sites, like the ovary, the testis, or the mediastinum.
So, what does this all mean? Well, it brings us to a rather profound final thought. From a simple thorn prick in a gardener's finger to trapped embryonic cells from before you were even born. Isn't it absolutely fascinating how the body's protective outer layer can create such complex, hidden mysteries when it gets displaced? Human biology is glitchy, sure, but absolutely incredible. Thanks for joining me on this clinical investigation. I'll catch you in the next explainer.